So welcome. This is another in the series of AONM, that's the Academy of Nutritional Medicine, webinars, and we're delighted to have Kunal Garg with us this evening and Dr. Aylin Ozdemir, and they'll be talking about PANDAS and ZEBRAS, rethinking neuropsychiatric diagnoses through the lens of Lyme disease and co-infections. And just a few words before we begin. Please do put your questions or comments into the chat or the Q&A. If you would like your chat to go to everybody, please remember to switch it to everyone because it can default to just hosts and panelists. And the presentation will last for about 40-45 minutes, and then there'll be good time at the end for any questions that you have. So we look forward to both of you. Thank you very, very much for being here. Kunal Garg is a biotechnology and nanoscience expert who I'm sure you've seen before. He's spoken with us and to us many times in the past. He specializes in diagnostic solutions for infections and chronic diseases. He's the co-founder, CTO, and shareholder of Tezted Ltd, a Finland-based in vitro diagnostic manufacturing company. He leads the development of innovative ELISA-based multiplex tests, including those for tick-borne diseases, viral reactivation, autoimmunity, and mycotoxins. So anything else he'd like to say about himself, he'll let us know later. He has a long, very impressive biography. And Dr. Aylin Ozdemir is a respected leader in pediatrics and integrative and functional medicine. She's widely recognized for pioneering evidence-based approaches to advanced medical care. She's served as the owner and medical director of Pediatric Associates of Jacksonville since 2001, a legacy pediatric practice originally founded in 1932, which she continues to guide with vision, innovation, and clinical excellence. She completed her medical degree at the University of Istanbul and pursued postgraduate training at Queen Mary's Hospital for Children in the UK. So that's fascinating, and she has close ties to the UK, as she'll be explaining to us. She then undertook extensive training, and of course, she's been working at that practice for 25 years, so lots and lots of experience. Her expertise in understanding and implementing numerous paradigms, such as how the environment, genes, and nutrition play a role in the whole patient systems approach, allows her to practice a distinctive and extremely effective style of treatment and care. So, Kunal and Dr. Ozdemir, over to you. Thank you very, very much indeed. Looking forward.
Thank you. Thank you. Hello, everyone. It's really great to be here again. Just so that you know how this webinar is going to go forward, I will start the webinar talking about the care guidelines. It'll just be about 3 to 5 minutes, and then you will all hear from Dr. Ozdemir, which is the main juice about PANDAS and ZEBRAS for this webinar. Next slide, please. So before we begin, I just want to let you guys know that over the last year and a half, we've been working very closely with Dr. Ozdemir, working on her really unique cases that she comes across in routine, and to report them in a structured way, we've used the care guidelines. And the care guidelines are very important when it comes to writing case reports or case series. So care guidelines essentially deal with case report guidelines. Next slide, please. So when we are dealing with different types of studies, you usually read on PubMed, Google Scholar, they usually follow a certain guideline of reporting or writing the paper. And this is very important to know because this benchmarks the quality of the paper or the study that you're essentially reading. So if you're dealing with a systematic review, you're essentially following the PRISMA guidelines. That goes same for randomized control trials. It's the consort guidelines. For observational studies, it's the Strobe guidelines. And when it comes to case reports, that is where we need to follow the care guidelines because it provides a systematic approach to reporting a patient's story. Next slide, please. So the care guidelines has essentially 14 items, and I will not go through all of them in detail, but the point is you can see on the left side of the table, you have the topics, then the item number, and then the checklist. So writing a case report is essentially marking off things from a care guideline because it tells you from start to the end what you need to write. For example, in the title, you need to include the word case report so that when a reader is reading it, they immediately know it's about a particular patient or not a group of patients. It can be different when you are writing multiple case reports within a single paper, then it is essentially a case series. Uh, then you go to the abstract, where you're essentially reporting the summary of the paper, the whole juice within 300 words. And this is wherein if a busy doctor is trying to get through the paper, they would probably just read the abstract and get over it. But then there are other people that do want to get into the nitty-gritty of the paper, and that is where the introduction comes in. Why do you think the case is interesting? The timeline about the patient, the information about the patient. Next slide, please. And then what kind of examinations has the patient gone through, the diagnostic assessment, what was the intervention that the patient was given with specifics, if it is antibiotics, if it's herbals, how was the patient followed up, and then in the end you discuss what really came about, how the patient improved in the outcome, and why you think this is the case. The one thing I think is very interesting from the care guidelines is the patient perspective. There is a special place in the care guidelines for patient's perspective. And this is very important from underserved diseases like PANS, PANDAS, or Lyme disease, because here is where you can also discuss patient stories. Next slide, please. So to work with Dr. Ozdemir, we had a very simple algorithm. We requested Dr. Ozdemir to just record her voice with meeting all the care guideline checklist. We used this to transcribe it. We, of course, didn't hear each reading and write it down. We just use a software to do the audio to text. We then organized it using various AI tools and our own writing skills. We reviewed it, and if there was any missing information, we went through the audio again. So what this has led to in a year, next slide, please, is as of today, we've got the information that our case series is going to be published soon. So you can expect an open access paper coming out. And with this, I give it all to Dr. Ozdemir to take over. Thank you.
Thank you so much, Kunal, and thank you so much, AONM, to having me here. And it's truly an honor. And the PANDAS is also so close to my heart. And first of all, I'm a mother and a pediatrician and practiced 34 years. So, and PANDAS and ZEBRAS and rethinking the neuropsychiatric diagnosis through the lens of Lyme disease and co-infections. And what's PANS? And the main difference between PANS and PANDAS and the no age restriction for diagnosis, but pretty much pathophysiology is environmental infectious or multifactorial acute onset neuropsychiatric syndrome. In the PANS and sudden encephalitic-like onset obsessive compulsive symptoms, severe eating restrictions, to concurrent cognitive, behavioral, or neurological symptoms, and could be multiple diseases or etiologies. When we say etiologies, and you'll see in the cases that I'll discuss later in the presentation, and we come across, there's never kind of one thing, and constellation of impact on the neurocognitive system. And the PANDAS is more pediatric autoimmune neuropsychiatric syndrome associated with streptococcus. And usually there's a history of strep and incitatory trigger. Acute abrupt onset is very important, but down the road, when I explain the cases, sometimes it's hard to pick. So it's very important to take a detailed history, and then so we can tie the onset of the symptoms to the initial insult on the patient, and often multifactorial. Symptoms first becomes evident between age 3 and before puberty, or I would say puberty also plays a huge role, and in the cases we'll discuss about that. And then presence of OCD and the multiple complex unusual tics, and sometimes bedwetting, changes in their habits, and neurologic abnormalities, and sudden onset behavior and mood changes. And there's always mood and also behavior and neurological, it has to be present. Because that's the main part that we can differentiate these patients with pure psychiatric conditions. That neurological piece needs to be paid attention to. And this is a good case of pseudonym chorea of a patient with and strep exposure induced pseudonym chorea. If a patient comes with the neurocognitive decline and regression with these kind of movements, and following a strep exposure, this is kind of a classical pediatric board question video. Or school-age child with typical movements of pseudonym chorea. It's could be related to neuropsychiatric illnesses, and then it could be then induced PANS flare. And then most important thing, taking very thorough history from these patients, because it's just really, we can label a lot of patients with PANS and PANDAS and flares, and we get those calls from parents, but the history is so important. And sometimes parents describe and dilated eyes and mydriasis that we call, and then vision issues, changes in their visual disturbances, and then nystagmus and hallucinations at night, and night sleep disturbances, sleep resistance, and fears. Sometimes all of a sudden they start, trichotillomania, hair pulling and skin picking behaviors. And history of exposure is very important. And then bug bites and trauma or travel history. And 80% of the PANS patients have joint pains and muscle aches, myalgias, inflamed, overall tired and fatigued that we hear from parents. Strep infection related peeling skin, hands and feet, or red anal ring, and then inflamed strawberry tongue. Those are the things that you might hear from parents or observe in the office yourself. Physical signs of other infections also needs to be paid attention to, like warts, ringworms, skin rashes, molluscum. That also kind of a clue for immune dysregulation. And cognitive and neurological behavioral symptoms is just really very rich in PANS and PANDAS patients. It could be like so many constellation of symptoms, a myriad of stories that we hear from parents. Sometimes it's really difficult to get those histories in the office. So a symptom checklist for behavioral neurological symptoms is extremely helpful. Anxiety, separation anxiety, child who was able to go to school all of a sudden resistant to go to school. Emotional lability or depression, aggression, severe oppositional behaviors. And sleep is a huge piece too, that always should be included in the history. And behavioral developmental regression. And that part sometimes in my patient population cross over with our autism population. It's very important to kind of just the label patient, not the label patient with autism, and miss that behavioral developmental regression due to multiple infections-induced neurocognitive behavioral disorders. So this is so important because sometimes when patient comes with sudden deteriorating school performance and in preschool or in typical age for autism presentation, but we don't want to miss that PANDAS piece and not provide patient the well-deserved workup so we can turn things around. Somatic signs and sleep disturbances, and we mentioned those, sleep and change in bowel and urinary habits. And handwriting changes. All of a sudden, patients lose their handwriting skills. And laboratory workup, and quite different for, of course, for conventional commercially available labs versus our functional integrative laboratories. So then inciting infection investigation is so important. And dental exam, looking in details into those children's mouth, perianal exam, lymphatic drainage. Sometimes they have a rash in the back of their leg. Could be erysipelas, haven't fully resolved, low-grade infections. And then strep throat cultures. Sometimes we culture perianal area, not just throat culture. And then bacterial and viral workup. And then, of course, and since the era of COVID have descended upon us, including COVID, part of your workup is also so important. And a list of infections described here, an immune workup of immunoglobulin levels. Because what is our baseline immune function for the patient? Do they have a normal total immunoglobulin level? And they may not even have normal immunoglobulin function, and yet we are expecting patient to have a normal, typical response to childhood infections or environmental infections. And then ferritin levels and the serum copper, B12, vitamin D, and then plasma amino acids, organic acids, stool testing, and infections and parasites. Thyroid function, mold evaluation, which is very big in our Florida patients. We see a lot of mold exposure. And then also inflammatory markers. And then I'll get into details of these chemical markers when I present the cases, because sometimes, low micronutrient levels also can trigger neuroatypical behavior. When we get into that brain chemical function, you'll understand how they play a huge role. So just infection by itself is not the culprit here. And PANDAS is often clinical diagnosis, but there are a lot of very helpful tools, and then molecular labs and the autoimmune brain panel, and then can help support guide treatment. I included Cunningham panel because formerly known as Cunningham panel, but molecular labs, and could be very helpful in terms of determining before and after treatment and care follow-up. Autoimmune markers, and molecular labs uses 5 main anti-neuronal antibody markers, but there are some other autoimmune markers that we use also from commercial labs, and they're available commercially. And other tests also, sometimes central nervous system imaging and baseline and cardiac imaging, especially for rheumatic fever patients. They may have sudden onset behavioral changes. We don't want to lose that carditis, and we need to include those workup as well. And also sleep disturbances, sleep studies, and could be helpful to understand where is the prevailing clinical symptom for the patient. And in few instances, of course, and we perform spinal tap for those patients, especially patients who might need a plasma exchange and immunomodulator dose IVIG or plasmapheresis. Understanding that anti-neuronal antibodies in the spinal fluid extremely helpful. So then, as an integrative medicine laboratory workup, and of course, I'm always for the toxins and trauma and thoughts, and my integrative approach is one of my actually strongest, and then where my heart is. And then because often you'll see, and never one thing, and Dr. Jones used to call them infections, and then stress the plural, and induced encephalopathies. And there's also integrative piece and environmental piece that we always and remember to carry that whole systems approach hat. So never forget about the toxins, and then could be congenital metabolic disorders and organic acid, and then also pyroluria. And that's also could be related to methylation defects, MTHFR mutation, and related disorders, and oxidative stress markers, which is we use through Genova labs. And then often we see very much oxidative stress evident even in children with 8-OHDG and lipid peroxidase levels being off the charts high. And then as we start treating patients, and they come nicely down. And mitochondrial support markers, and sometimes gut integrity workup is very important. A new gut integrity functional integrative labs that come in, and they're helpful because leaky gut is leaky brain. And then when we get into the brain anatomy and then talking about all the molecular steps in the brain, you'll understand and have them monocytes and the macrophages crosses that blood-brain barrier, and it can actually break the dam. And all of a sudden, sudden onset of symptoms might be coming into picture. And the functional hormonal balances are important because for neurocognitive integrity, we need to be able to have our pituitary hormones in place. And also histamine levels as they readily cross blood-brain barrier. Histamine markers play huge inflammatory role in PANDAS patients. And in nutrition deficiencies, and when we get into tryptophan pathways, you'll understand how those micronutrients plays a huge role and in terms of determining outcomes for those patients. And another favorite topic of mine is mast cell activation syndrome and the SIRS. And the SIRS kind of came later on mainly for mold exposure, chronic inflammatory symptoms, but it's kind of mast cell and then histamine-driven patients that is just kind of more clinically, I would say, alarming because they've got more acute and very exaggerated symptoms rather than chronic. So, and then this is one of the labs I use. And I wanted to just kind of use Geneva labs and simple, because when we see major oxidative markers in here, and then we know that blood-brain barrier is at risk. And then for penetrating those and triggering and kind of chemical ingredients play a role of PANS and PANDAS picture. So without really creating the biochemical homeostasis balance for the patient, we wouldn't just go after an infection with a sledgehammer. That would be a very reductionist approach to PANS and PANDAS management. So then healthy brain and also will be in the healthy body and healthy chemical balance. And then this is our famous Krebs cycle and citric acid cycle. And if you can actually simply pay attention to this cycle, fats and carbohydrates, proteins all rely on micronutrients to create energy by using our powerhouse, which is mitochondria. But then if we are in a state of major oxidative stress, and our mitochondria will not work, and then brain function will be compromised. So without really having fats and carbohydrates, proteins properly assimilated to provide support for our brain function, and then eliminating an infection, also pretty short-sighted. And this is, I think, something that I just cannot stress enough. It's just very, very important piece in our whole systems integrative approach. And then if we come to brain quinolic acid, because part of that functional test I use from Genova Labs, and then we see also quinolic acid and go high, which is the precursor of tryptophan metabolism. It is kind of very helpful to make NAD. It's kind of one of the super smart molecule, but when we have other players in the game, And then all of a sudden, and then quinolinic acid pathways get kind of quite disturbed, and the neurotoxins and quinolinic acid becomes the hallmark of that kind of brain on fire picture, acting as a double-edged sword. Quinolinic acid is both an essential precursor for NAD biosynthesis and potentially toxic metabolite at high concentrations. And animal studies showed the concentration of the quinolinic acid in the brain was directly associated with the neurologic and some behavioral outcomes. And then infections also could be a huge trigger for increasing quinolinic acid levels. There's an abundant evidence that urinary quinolinic acid is increased in various states of infections. And then inflammatory triggers also create complex cascade of reactions in chironin KP pathways, causes quinolinic acid accumulation. And then quinolinic acid and infection level, as the quinolinic acid level increases, various factors, inflammation and neurologic disorders will be very evident. Sometimes we receive patients, international level, these labs for quinolinic acid levels without even seeing their history. The things come across our mind are is a patient is autistic, or they have PANS or PANDAS, or is there a regressive behavioral, acute or subacute, sometimes chronic neurological symptoms in these children. And this is not just one marker, but one of the important, I think, chemical marker that we need to pay attention. And then infections can increase quinolinic acid level, very well published. Also the toxins and heavy metals, mycotoxins, strep bacteria, and then we look at also strep enzymes to correlate that to them, because I can't readily check for every patient quinolinic acid levels, but I can check some of the streptococcal enzyme levels, or we can do viral and bacterial workup. And then in part of the history, and then heavy metals, and then traumatic brain injury, mycotoxin exposure should be definitely asked in the history and or tested. The reason I added infections and traumatic brain injury, mycotoxin and heavy metals on the same slide is often overlooked topic is when there is a traumatic brain injury, blood-brain barrier opens up and infections will readily travel to the brain. So then all of a sudden double biomy, but then most often we see more than double biomy for these patients. Same thing, mycotoxins often makes the blood-brain barrier weak, and then we'll see penetration of the infection and hiding in that, biofilm, and all of a sudden it's readily available for the brain, and heavy metals also kind of like to partner with the candida and other things. And now we know about COVID, and COVID is living in the phages in the gut study. And then for the COVID long haulers, and I call them all my PANS patients actually, and then also work on the same mechanism of action is COVID SARS-2 is hiding in the phage of the lining of the intestinal permeability, and the same thing in the brain blood barrier, and then readily available and after acute infection. And all triggers the macrophages to produce massive amounts of quinolinic acid, which becomes neurotoxic. And this is kind of one of my favorite slides, and shows the blood macrocapillaries in the brain, and then blood-brain barrier, and have the ion channels and changes because of the multifactorial points that I made earlier slide, and then how can actually activate the macrophages and the microglia, and the monocytes play a big role. And then all of a sudden, and we've got this influx of quinolinic acid, which plays a huge role in neurotoxicity. If we would have right amounts of it, that would support the NAD pathways. But unfortunately, in the era of environmental diseases and toxins, and then SARS, COVID, and the mycotoxins, and the climate change, and our blood-brain barrier is not serving us as good as it used to, and then queen uptake and accumulation, and saturable, and then taurine and neurofilaments, and hyperphosphorylation, and changes brain's oxidative stress. And then cell types, it could be looked at, some of them commercially available labs, and then activated lymphocytes, Th1, Th17, and then you can look at the patient's phenotype. Are they more like an allergy-induced type of patients? So this is very important because, you know, when they're T-activated allergy type patients, those are the patients histamine overload, and they will be also more prone to develop PANS and PANDAS. And I'm a clinician. I'm not a molecular biologist, nor am a major researcher. I love to write up my clinical cases, but then being able to clinically correlate what we learned in pre-med, our molecular biology, and our pathophysiology is so important. So we're not just, yep, we found the infection, let's kill it. It's not your really highway to finish line and for these PANS and PANDAS patients. And the monocytes is one of the white blood cells and plays a huge role into the macrophages and dendritic cells. And macrophages, microglial cell, oligodendrites all get exposed to that storm, and what we call it brain on fire. And cell functions and pathologies, and then these are the cell types in the brain, and with the disrupted blood-brain barrier and then a loss of integrity, allowing harmful substances into the brain and contribute to inflammation or neurodegeneration. One part is very important, regressive autism. This is something that we need to definitely pay attention, because then we know that cholic acid causes astrocyte and microglia to go into apoptosis, and we might be losing neurological cells. And then what we call as a regressive autism or PANS PANDAS flare, in actually molecular level, we need to remember, and the cholic acid, if it's excess, it's causing an apoptosis and then cell damage and then disruption and then cellular death, and something that we need to remember. And then these are the some of the inflammatory markers and compounds, and then we can use, and part of the testing to support our hypothesis. This is actually, you know, contributing to the neuroinflammation, and they're very active, of course, in the central nervous system. And then when the cholic acid partners with the NMDA receptors, and then NMDA receptors, and then kind of go out of order, and we have this glutamate excess. And with glutamate excess, which is a neurotoxic, or we call it excitatory toxin, and kind of messes up synaptic responses, and then it's associated with the brain plasticity and memory and overstimulation, and Quinn-led neurotoxicity. Here we go. Now we have to deal with an NMDA receptor dysfunction and glutamate excess. And then molecular labs allows us to look at the antineuronal antibodies, and major 5 of them. And it's very helpful for us to actually guide ourselves and for the outcome. And before and after testing is very, very helpful. And then, of course, you'll have to clinically correlate. We're not just relying on the lab test, but then clinical correlation and supporting our outcome. And then sometimes also convincing parents, look, things are getting better. There's a hope. It's a very helpful tool. And then these are like 2 pages of, actually, I love this slide, a very busy slide, but 2 pages of and micronutrients and how they can actually alter some of the compounds in the neurotransmitter level. And then melatonin, how it can actually help And then even saffron is mentioned here for brain function and brain antioxidation. And then I love using a couple of products available in the botanical world. And then iron, how iron actually plays a role, certain, actually even prescription drug, a cyclovir, how does it affect and reduces necrosis of hippocampal neurons. Sometimes we use it actually off-label to stop that hippocampus dysfunction. And then, of course, L-carnitine, acetyl-carnitine, these are active, neuroactive compounds we use in integrative medicine. And then we use L-glutathione, that's the most researched one, reduce oxidative stress, and then reduce glutathione, and then selenium, and then safranal, and is mentioned here. And then how does Alzheimer patients actually have impact on the microglia, and then what kind of chemical components actually going up and down for those patients, or Huntington's chorea, and all these colonic acid related pathways. So then when patients present with these kind of choreas, we might diagnose, but then we need to remember that they could be also infection triggered. And then there's such a good slide, but then I think on a good day, and it's well worth sitting and studying this slide. And then curcumin is also mentioned for anti-inflammatory properties, inhibit quin-induced oxidative stress, and subsequent nitrite production. And it's just very helpful for our patients. And then that's kind of a larger picture of the previous slide for us to understand and the blood-brain barrier, and then how it end result in the mitochondrial function in the brain, because at the end of the day, it's all about mitochondria, and then ATP production. And then when the patient's tired, when like 3-4-year-old, they go 2 hours of raging with PANDAS flare, and they're exhausted to go to school in the morning. So those are the factors we need to remember, how actually mitochondria damage can lead to caspase activation, DNA damage, and a cellular death in the brain tissue. So those are the things that we need to always clinically correlate. And then multiple mechanisms, toxicity, and then I'm not going to just beat this chemical compound more, but it's that's just kind of DNA damage and cellular death is described in this slide in the previous picture. And then higher the levels of this chemical compound is the higher the pathological outcomes. Now we're not able to promote NAD production, and then all of a sudden we're just almost kind of a dam broke, and then we cannot patch those holes with NMDA receptor drugs, active drugs. We need to actually patch that leak, and I'll explain that even more in detail, how the elevated levels disrupt glutamatergic neurotransmission and damaging NDAR expression. So, but then NMDA receptor active drugs fall short, and because of the multi-level damage here. And then kind of then NMDA receptors play a role, but we can't help and to stop these active agents constantly damaging the brain by just blocking the receptors. So I give the example, patient dam broke, we can't just patch the holes. We need to just do everything within our power to close the blood-brain barrier, and then improve cell communication and cellular membrane level. And a membrane medicine is a very good approach to that. And also remove my triple T's. And then I always call it trauma, toxins, and thoughts, because indigenously in high anxiety, cortisol production, high cortisol also play a role sometimes. So that's why the mood management, stress control, stress management, mindfulness, and also plays a role when we approach these patients' successful recovery. And then my first case is 15-year-old male, and diagnosed with PANDAS, but in a couple of years down the road, because he was pretty depressed and didn't want to go to school, and diagnosed with depression. There was a sudden onset, and there was no really rhyme or reason he didn't want to go to school. But then overnight kind of became depressed and a school refusal. And then plateaued response to treatment for depression. Then we said, okay, sudden onset, we have to look at these things. This was a couple of years back. And then he also had POTS. So then strep disease was diagnosed in the history. And then also POTS, postural orthostatic tachycardia syndrome, became more evident as he get into puberty. And then very important to understand that these patients often have impaired circulation in the central nervous system. And it's kind of a hallmark of POTS. But then when we diagnose patients with infection and provide infection approach, and all of a sudden we are plateauing in the treatment response, it's very important to remember and what is going on in the environment, trauma, toxins, and thoughts. And I mentioned earlier slide. Because often when we use the molecular panel, then we'll see the antineuronal antibodies, and then patient has POTS. We know the permeability of the brain is also quite leaky. But then very important when we give these patients immunomodulator dose IVIGs, we have to be very careful, because when the blood-brain barrier is quite impaired and high doses of hyperosmolar IVIG, patients will develop more aseptic meningitis. And that was the case in this patient, and we learned. So if the patient has POTS, we know their brain permeability quite compromised. And then even though the immunomodulator dose IVIG provided great recovery from severe case of PANS and PANDAS for this patient, but they're complicated with the aseptic meningitis, and then taught as a lesson, we need to treat these patients with a lot of tender loving care when we give them immunomodulator dose of IVIG. So then after that, and the patient's US labs were negative, but he was still symptomatic. So I reached out to my trusted friends in Finland and Tezted labs, and indicated, and Tezted labs, of course, and then indicated positive response to Borrelia, and then myriad of other co-infections. So then that kind of taught us we need to just go extra mile when one lab is negative, when we need to just kind of persist, to be tenacious to find other answers for these patients. And then we also provided this patient IV nutritional therapy, because often, and as we showed in an earlier slide, and their mitochondria is not working, their Krebs cycle is not working. And then what happens when that happens, and they have high lipid peroxidase and high 8-OHD oxidative stress markers. Our job is to cool off the fire in the brain. So we use orthomolecular medicine. And then my fastest way to get the brain by doing IV nutritional therapy. And I combine that with the oral nutritional therapy. And then also, if they don't respond, treating infection. And then I always look for toxins. And then we found mold exposure in this patient, recently moved to a beach property, and his symptoms flared up. His POTS gotten significantly worse. And with the puberty changes, it did not help. Why puberty is so important, okay? And even though PANDAS kind of cut off puberty, and then I think it's so important why puberty becomes the kind of a Bermuda Triangle, like almost we're passing the Bermuda Triangle. We might get in trouble. And so because in the same pathway detoxes in the brain, so many neurotransmitters, like uses also hormones, hormone detoxification. And then COMT mutation plays a huge role on that, because the glutathione pathway detoxifies the hormone byproducts, also detoxifies the neurotransmitters. So it's very important to check patients for COMT mutation during puberty, because those are your kind of worst cases. And with the puberty, all of a sudden, and then patients will be symptomatic. And then in Florida, we also kind of add some other things on those patients. And around 12 years old, they get their 7th grade vaccines, and parents kind of go in the, oh my gosh, the vaccine might have triggered, but then always multifactorial. And then I will keep the vaccines outside of the discussion of this presentation, and because we want to just focus on more like excitotoxins and neurotransmitter toxins. And then when the certain SNPs, MTHFR and COMT is not working, especially during puberty, we get a huge kind of almost like a surcharge of neuropsychiatric imbalances. And then that needs to be tested for patients who became more symptomatic during puberty. So this patient, of course, received some antibiotics, but it was only for 1 month, because we were in the tail end of his recovery journey. And also this electrolyte and hydration therapy balancing for POTS. And then he had complete recovery from PANDAS, depression, anxiety, and POTS. And then one thing in his case was I think was hallmark of my learning experience was, and then regulating electrolytes for PANDAS patients improves their POTS symptoms. And then if you also think of kind of an average food supply in the United States of America, and often reverse osmosis, often is kind of goes through so much cleansing chemical processes, it's very important to provide patients and all the mineral available in our bodies, ideally high quality, and artesian comes directly from earth, and then ocean minerals has often 99 minerals. It is very important to regulate the brain ion exchange. And then when the patient becomes often POTS symptomatic around puberty, think of their electrolytes and ask their source of water. And in my office, we can just get them better overnight, because I do a lot of IV nutritional therapy. But then if you don't have access to it, always use things like Quinton water, plankton water, ocean minerals, get these patients mineral balanced. And then this patient did not need any further antibiotics or IVIG. And then we continued through symptom checklist and regular follow-up. And then case 2 is this is kind of a patient had a very long history of, I would say, 20 years of history, but we were able to collect this patient during this time, that history. And then 24-year-old female with the neuroatypical behavior since infancy. And then hallmark of this patient was cycling flares of good days and bad days, and then flares. So sometimes parents don't remember when was the main symptom of neuroinflammation. It's very, very important for us to remember patient will have multiple episodes, maybe not one episode. So then, patient present with behavioral neurocognitive difficulties, immunodeficiency, and with the very significant low IV immunoglobulin G, and received many years of IVIG. When IVIG did not respond anymore, patients' cognitive regression and then cycling neuropsychiatric symptoms and cognitive regressions, good days and bad days at school, and around 10 years of age, and patient underwent, unfortunately late, infection-induced encephalopathy workup, and when she's diagnosed with Babesia, Bartonella, and Lyme, and then She was treated and also went through the membrane medicine treatment. And after 17 years of IVIG, she actually outgrew any more needing IVIG. And on a very good note, after exposure to COVID, she had only 3 days runny nose, no hospitalization. And this is the same patient actually had over 2 dozens of hospitalization, near-death experiences, and recovered from COVID in 3 to 5 days. And then, and after COVID, and then patient probably around 2 years after COVID, and she also had immune dysfunction. At that point, and we just kind of, there's no antibody response. We're not able to prove what she has. We need to reach out to our trusted friends in Finland. And of course, tested lab, SICK-Blast was negative. But then, and as patient later on, T labs showed an reactivation of this infection after COVID infection. So then IV nutritional therapy, electrolyte and balance, and then a multidisciplinary approach provided, again, total recovery from her symptoms, and then no need for antibiotic or IVIG needs. And then patient currently neurotypical and attending college. I'm going to have to speed up because I have 10 minutes left, and I don't want to take up all the time from the questions. And then this is actually, this is one of my favorite cases, and 21-year-old male with history of learning disabilities, and then kind of a recluse, socially withdrawn, and teenager, and then start self-medicating in late teen years, ended up in one of the major hospitals on my neck of the woods, and very kind of an international referral center here in Jacksonville, and was diagnosed with and the multi-axonal demyelinating polyneuropathy, and then he was dependent on wheelchair full-time, and with severe neuropathy pain. We couldn't even touch this patient. And then he was hospitalized with alcohol delirium, chronic alcoholism, and his labs were negative and for infections-induced encephalopathies in US commercial available labs, and this patient's specimen was sent to Finland. We were able to diagnose him with Bartonella babesia infections as the root cause of his neuropathy. We treated him 6 months with the multidisciplinary approach by using, of course, my whole systems approach with IV nutritional therapy, nutritional support, and then detoxification. Within 3 months, patient was off the wheelchair, and then he was pain-free within the first 6 weeks of our intervention. And then this case highlights the complex interplay between Lyme disease and co-infections, and alcohol was used in this case as a kind of maybe coping mechanism. That's my clinical observation. And then sudden onset of neurological compromise after binge drinking. But then his clinical picture at the referral center, tertiary referral center, was only chalked up to, oh well, and alcohol caused acute axonal multi-demyelinating peripheral neuropathy. Now you'll be depending on wheelchair rest of your life. And this patient, I'm not going to get into details, but then he is very physically active and is working full time and then free of pain and infection. And then, and this case 4, I'll briefly go over this case because sake of time. She actually came to me from out of the country, and she had an extensive workup in her country, and then she was diagnosed with regressive autism, but then after an infection, she regressed further after she recovered from her regressive autism. In other words, she had responded by a medical intervention and recovered from that regressive symptom, but after an infection, she regressed again, but did not recover. So this case highlights for me the importance of infection workup for anybody who had this kind of picture. And due to, various reasons, this patient's family did not really do the infection workup, but my biomedical workup showed that from early on, even infancy, when this kid was regressing, she had very high pyruvic acid and lactic acid levels. So it's very important for us to remember some of these patients has a congenital case of mitochondrial disorder, will further compromise with toxin overload and infection exposure. So then we just can't just say this, oh, okay, after infection, she regressed. She's got PANDAS, and then use that as a label and overlook a mitochondrial disorder she had since birth. And this highlighted that for me, and I wanted to share with everyone. So unless you do thorough workup, it is very difficult to really diagnose these patients properly. And my last case is
Dr. Ozdemir, would you mind if we stop now? And we might continue on to the next case afterwards, but we've had so many questions because your cases and also your previous explanation has been so fascinating that I don't want us to curtail the time too much. Is that all right? Because some people need to leave. We had only said it would be the hour. Oh, just tell us who that is. How lovely.
And this is Dr. Charles Ray Jones, and he has been a mentor in my life, probably and 20 years or 25 years of my children's life. And I just wanted to dedicate this presentation to him. He was super instrumental in our recovery and learning infections, plural, induced encephalopathies.
Yes, he was a fantastic doctor in this field, wasn't he? Went on working until I think his 90s.
This is his 92nd birthday, and he lost 24th.
Amazing. Yeah, very, very special. Well, thank you so much. There are just so many questions that I think we're going to need to have you back if we can, but also, so have you present further cases. But let's just look at a few of the questions. Is that all right? If you discontinue sharing, maybe, if that's possible. You able to stop your sharing?
Yes, sure.
Lovely, thank you.
Thank you.
I'll go to the top of the chat and just start going through fairly sequentially. So one of the first questions was, Bernie wondered whether you found hydrocephalus in your patient population. I know you did mention head injuries, but do you actually note sort of intracranial hypertension in any of your patients?
And we don't get to check the pressures of the spinal fluid routinely, but we have had checked that spinal fluid pressures in quite a few cases. One other thing is pseudotumor cerebri should not be overlooked for these patients. And then they act like, and they've got tumor in the brain, and their papillary exam, eye exam is abnormal, but pressures are high. It's also something that should be in the differential diagnosis, but the hydrocephalus specifically, and then I didn't have any patient.
Okay, thank you. There are, lots and lots of thanks and appreciations of how brilliant your presentation has been. Another patient asks, or therapist asks, what specific co-infections tend to be most commonly overlooked in neuropsychiatric presentations?
That is actually a great question, because it changes where the patients are coming from.
Oh, yeah. Mm-hmm.
You need to know your terrain.
Mm-hmm.
So it's very, very important just like to understand where this patient came from. In Florida, we just got mycotoxins. And then in New England, I may be checking more weird forms of Borrelias. Mm-hmm. And then it's really very important. You need to know your terrain. And what I see commonly in my area might be different than what you see commonly in your area. But then there are certain ones we see more neuropsychiatric symptoms than typical like fatigue and Lyme-induced encephalopathy. I mean, Bartonella could be probably played a big, and kind of he's a big player. That's kind of our, I call it gangster, Barto gangster, I call it.
Mm-hmm. And do you wean patients off psychiatric drugs if they have PANS? And if so, how slowly do you taper down, and what support is given to moderate withdrawal symptoms?
Yeah, years ago, and I did training also psychiatry and primary care pediatrics. So I have a psychiatric also training. That was kind of, for me, was like necessary because like psychiatrist wasn't able to see from the lenses that I was looking at these patients.
Yeah.
And then often when we diagnose the patient correctly, they get better, and then we are able to taper their psychiatric active drugs. But then I also say the flip side of it, if the diagnosis is wrong, often patient will not get better. So then, the most important thing, that finding what is the culprit, and then anchoring that, then later on, of course, tapering.
And do you taper down very, very slowly? Do you do that together with their psychiatrist, or do you find you can do that yourself?
And depends on the patient's diagnosis. And then if the patient has like, I don't want to actually label patients because I want to see them as a person, like, and I don't want to use a psychiatric diagnosis for the patients. I will say infections induce encephalopathies for the sake of this presentation. Because I don't want to identify a person with a psychiatric diagnosis. And it's often because there becomes an imprinting, often we're able to take those labels off patients. But if the patient has got 5 different psychiatric drugs, then one of my mentors taught me years ago, like if the patient comes with ADHD and anxiety, you treat the anxiety first. But what you treated first may be that, like, the last one to kind of you stop. So there are certain clinical algorithms I use and based on clinical sense.
Right. Peeling the onion. Yeah. Lucy asks, which IV nutrients do you provide, and does it depend on test results?
And sometimes I do biomedical testing in functional labs, and sometimes I don't. And often I clinically correlate them. Micronutrients I use, and a lot, just like a lot of them. And it could be something like the B complexes. If you remember the pyruvate pathways and goes into the Krebs cycle, often these patients are B complex deficient. That's kind of one of the things that I have to balance that. If the patients are not responding well, the B complexes, that's also another red flag for me. There's an infection there. This is not just what we are dealing with. Or if you give them glutathione, all of a sudden they're like having headaches. Those are toxic patients.
Yeah. And what nutrients help decrease leaky blood-brain barrier when there is no leaky gut?
Okay. So, okay. And sometimes, and not very often, but we also do the microbiome test. So this kind of, now we are able to use the entire gut microbiome. So we need to understand what are the players in that biome. If a patient has certain strains of a biome, we change their diet around, and then to be able to re-regulate, and then what organism we want to actually express, what organism we want to suppress. And just by doing that, we just help the leaky gut, and as we help the leaky brain. But there, of course, there are certain micronutrients, and like, for example, and used often for leaky gut, like L-glutamine, but could be actually poison to increase glutamate for the leaky brain. So we have to really be very careful and not throw supplements to those very sensitive patients.
Thank you. And if PANDAS is diagnosed years after the initial infection, is it still okay to give the patients antibiotics?
And based on their lab results, if there's an active strep enzyme, inflammatory markers, and then you need to find a source. Where are they? And then you always look for the co-infections, and there's never one thing is playing a role often. And also, like, kind of nature-nurture balance, you also kind of build the patient to find that equilibrium.
Okay, thank you. And if infusions are not possible, I think PK here is meaning perhaps the phosphatidylcholine infusions. Then what are your oral considerations?
I mean, there are some products available for oral consumption for the same nutrients.
Mhm.
And then if they're being consistently given with gut support, like, I mean, if patients come and ask me questions a lot on like, you know, this happened, this has happened, this is the one culprit, like a red 40, but then that's maybe not that really food dye caused that, but it's important that patient's diet to be clean. And then like glyphosate treated and gluten and
Yeah.
like and then growth hormone injected animal milk. So like those are the things should be eliminated, and then that's just the environment needs to be cleaned. As we change the diet, we supplement with micronutrients.
Of course. Yeah. And there are several questions here about potential tonsillectomy. When do you feel that a tonsillectomy is indicated? And if it does appear to resolve the issue, do you then assume that strep was the root cause?
It's another great question. Thank you so much for asking this question. Okay, I mean, tonsils play a very important immunologic role. And first, I would say probably 10 years of patient's life. But then they also, if they appear, clinical exam is so important for these patients. If they have cryptic tonsils, these patients have ton of biofilms. And if the tonsils are very cryptic looking, they're kind of almost like craters inside them. And then they're often hard to just swab and find the infection. And all of a sudden, not only strep, multiple organisms there living in a biofilm pool. And then they may need to come out. But very important thing for the tonsillectomy, and I partner with my local ENT doctors and always advocate before, during, and after tonsillectomy, and then surgeon to infuse this patient with intravenous and antibiotics.
Oh, brilliant. And that will be an ENT doctor who really understands your approach then and understands these kinds of conditions, right?
Because when the tonsils are removed, the blood-brain barrier opens up, and there are a lot of clinical pictures like that. When the blood-brain barrier open up, we don't want that infection from the tonsillectomy procedure cross more blood-brain barrier and then cause more influx of cholinergic acid drive and an excitatory drive and increased glutamate pathways. So we want to decrease our burden very low as we remove the biofilms and then areas of locked off infections.
Okay, thank you. Perhaps one last question. Do you treat infections with herbal medicines? And if so, what's your sort of algorithm for deciding which to use? I know that's a big question, so you might only want to touch on that.
Yeah. As I, you know, I'm fellowship certified from University of Arizona Center for Integrative Medicine, and I'm also so I'm botanically certified, and also I'm homeopathic certified, and in Chinese medicine. So we use sometimes Chinese medicine herbs. And I actually, years ago in ILATS conference, I presented an abstract on that by using biocidin.
Oh, fantastic.
And it was one of my to-go, and it still is. And then I use botanical medicine part of my interventions. And then once the article fully published, and they'll be able to access that information.
Well, you have an article being published on botanical medicines very soon.
And the article that Kunal mentioned is also including this integrative approach.
Ah, fantastic. When do you expect that to be published?
And then I think it's open source access, and probably within the next month.
Oh, brilliant. Well, if you could let us know when it is published, then we'll send out a newsletter with it. Is that okay?
Yeah, I can let you know.
Yes, please do remain in touch with us about that. Well, Claire, if we could possibly save over all of the questions, because we've got many, many more, and they're fantastic questions. So we will, I hope, have you back again. Perhaps when that article is published, Dr. Ozdemir, so you can talk to us a bit more about it. That sounds like a good idea, doesn't it?
Thank you so much for having me.
Yes, no, thank you. And I know that Dr. Garg has a couple of further announcements that you wanted to make. Thank you very, very much again, Dr. Ozdemir. Don't disappear, because I'm sure we'll have another couple of words together. But Kunal, would you like to just make your announcement?
Yeah, so I'll just share my screen quickly.
Yeah.
And so, yeah, just a quick announcement. we have similar, like we will have Dr. Aylin at in Finland actually in September. So we have this conference, which is the chronic infection pathology with the theme "Show Me the Data." It's from the 5th of September to the 7th of September in Jyväskylä, Finland. This is where me and Leona are based. And so the registrations are on. You can also submit an abstract, and you can also see the preliminary program on this. And this is very interesting because we are bringing chronic pathologies that was organized by Dr. Aman and Sigrid Blele, and crypto infections by Dr. Jack Lambert together under a single umbrella. And we will be talking about a lot of different topics, which includes big data, AI, but specifically in the context of today's webinar, integrative and personalized treatment strategies. So we have the abstracts open. The conference will be CME accredited, and then yeah. So please check this out. Claire has put the link in the chat section. So if you're interested, please do participate. Thank you.
Well, thank you very much. We'll be sending out details about that, and I'm sure you know how to book hotels. That you'll probably have a contingent of hotels there booked and so on. So thank you very much. Very, very much looking forward to that. I just want to mention that Professor Craig Shimazaki, who runs Moleculera, he's the CEO, and we've had interviews with him many times here. He is actually coming over to the Integrated and Personalized Medicine Congress that's taking place here in the UK. It's always the biggest summit that there is in the UK at Westminster, about 2,000 people a day. Brilliant talks. It goes on for 3 days. It begins on the 19th and goes on till the 21st of June. And he will be speaking from the podium on the 20th of June. And his topic is very similar to today's. It's really a perfect link: understanding the connection between infections, the immune system, and the brain. Can infection trigger neuropsychiatric symptoms, and how can you know? So please do come along to that if you like. Contact us because we do have free tickets to the exhibition area and the workshop. So contact aonm.org at the info. Claire, please put that in. I'm sure everybody knows it, but perhaps put in the address to write to for those tickets. And we do also have a workshop next week on Tuesday with a NutriMedics expert called Dr. Debbie Hamilton from the States, and she'll be talking about navigating Lyme, co-infections, and chronic illness with NutriMedics. And that's Lyme month this month. So again, it all fits together, doesn't it? Today was so much about Lyme and co-infections too. And Professor Craig Shimazaki will also be speaking on Thursday, the 29th of May. So all of those details will be under events on our website. So thank you very, very much again, Kunal and Dr. Ozdemir, and Leona as well, Professor Gilbert, for being here today. And thank you all the participants for being there with us. And this recording will go up on the website very, very soon. The slides we can't put up at the moment simply because a few of them are being used for publication. But after that, within about a month or so, we will be allowed to put them up as well. So again, thank you very, very much, everyone.
Thank
you. See you again soon. Bye-bye.
Thank you, everybody.
Thank you.